Hi everyone, good morning. My name is Eric Reith and I'm the Safe Pharma Program Manager at Healthcare Without Harm Europe and most importantly, the host for this session. I was about to say that I'm joining from a heat wave, but pretty much the whole Europe is going through that right now. So let me remind you to get a glass of water and stay hydrated, especially those in places that are not adapted to extreme heat, like London, for example, where we were yesterday also in the middle of a heat wave. But you came to this session not to hear about heat waves, but to talk about pharmaceutical redispensing. Redispensing of medicines has emerged as a critical step towards reducing the thousands of tons of pharmaceutical waste generated in Europe each year. And recent studies have shown that redispensing can result in a 68% reduction in pharmaceutical waste and also in 2 kilograms of CO2 equivalent per patient per year after process optimization, and of course, reducing costs. Now there is a window of opportunity with the new reform of the EU pharmaceutical legislation, which opens the door to widespread this good practice across different EU countries and dramatically reduce pharmaceutical pollution. In this session, we will therefore identify high-impact strategies for optimizing pharmaceutical redispensing and also evaluate how feasible these strategies are. And for that, we are very honored to have two pioneering initiatives in redispensing in Europe, one in the Netherlands and the other one in Denmark. But before introducing our great speakers, let me explain to you a couple of quick points. First, please note that this session is being recorded and will be available on this page shortly after the session has ended. So feel free to share it with your colleagues attending CleanMed if they are attending the other session that it's running in parallel. Please use the live chat tab on the right side of your screen to add any comments or questions to our speakers and specify who your question is for, and we will do our best to answer as many as we can. Also, please feel free to write where you are joining us from and what's your affiliation. That will help also other people to contact you and get in touch with you if you're working on the same topic. And if we don't have time to answer any question, then the speakers are encouraged to answer them in the chat after the session. Otherwise, please feel free to engage directly with any speakers via their profile. And with no further ado, I would like to introduce our first speaker. So we have two researchers joining us from the Netherlands, Lisa Marie Smale, pharmacist, postdoctoral researcher at Erasmus University Medical Center in Rotterdam, and Ella Johnson, PhD candidate from Houtwood University Medical Center in Nijmegen. Welcome to the floor. Welcome to the conference. I'm giving you the floor. As you can see, heat is already playing with my brain. I hope it doesn't do the same with you. But yeah, the floor is yours, Lisa Marie. You can go ahead.
Well, thank you very much, Eric. And I'm really happy and honored to give you a brief overview of the insights from the initial studies on redispensing unused oral anti-cancer drugs from the Netherlands. Waste of oral anti-cancer drugs is quite a burden to our healthcare system, as 1 in 3 patients have to discontinue their treatment early, for instance, due to severe side effects causing toxicity, or due to progression of the disease, so inefficacy of the medicines. And these events are really hard to predict. So upon discontinuation, half of the patients have redundant drugs that, according to the guidelines, fall to waste. So we just have to dispose of them, even though they have a really high economic value, costing on average 2,600 euros per patient. So accordingly, I think we can all agree that we're just wasting valuable healthcare budget here. But also we're contributing to climate change and pharmaceutical pollution by just disposing of good quality drugs that do not provide any benefits to our patients. So therefore, we strongly believe that we must come up with a more responsible way of using our medicines, at least by preventing medication waste. So we looked into circularity to conserve resources for pharmaceuticals. And I think with all things, it's better to prevent than to mitigate. So that's also the case for waste. In the first study, we tested if we could reduce the amount of medicine waste by just reducing the quantities that we dispense to our patients. So in this study, we came up with individualized dispensing quantities based on personal circumstances of our patients, and we evaluated how that influenced the waste of patients starting with oral anti-cancer drugs. We found that we could prevent 1/3 of the waste just by asking simple questions like when is the next appointment in the hospital, and individualizing the dispensing quantities based on that. However, we also found that 2/3 of the waste was not addressed because it was so hard to predict when it would occur. So therefore, we would need additional circular strategies. So that's why I think we must explore reuse strategies. And when I say reuse, it's not really reuse because we're talking about collecting the medicines that are left over at patients' homes to verify their quality, to then dispense them to other patients. And as they are not being used in the first place, we're talking about redispensing rather than reusing. So we did quite some research on this redispensing idea starting in 2014 and still up to today. We're working on this topic. And in this presentation together with Ella, we would like to give a brief overview of everything that has been established ever since. So first, we thought it was very important that we would come up with an evidence-based approach supported by the literature on the topic, on stakeholder support, but also on emerging technologies like time temperature indicators that allow monitoring of quality. So we used that in our initial feasibility research, in which we showed that stakeholders are supportive of the idea of redispensing as long as drug quality is guaranteed. Like I just mentioned, the time temperature indicators, and we can easily use them to verify storage conditions at patients' homes. However, these indicators are costly. So it would be cost beneficial to execute this approach for medicines that are more expensive than 100 euros per package if they are being stored at room temperature, because that usually goes well. That's why we focused on oral anti-cancer drugs. They are frequently wasted, they are expensive, and they are stored at room temperature. However, cancer is also a really severe disease, and the quality of these drugs is essential because they are literally saving lives of our patients. So before starting the redispensing program, we interviewed 17 patients who were living with cancer about how they were feeling to participate in a redispensing program and what they would need for that. This was back in 2020, and actually I was quite surprised by these patients because they were so ill, but still they would be very happy to give back to society based on a gratefulness for receiving such important life-saving treatments in the first place. However, obviously, they would require trust in product quality, which they could obtain through adequate information. And also, they said it would be nice to have easy return options for redundant drugs. So we used all that information to develop the quality assurance program. In the picture, you can see that we are enclosing each drug package in a sealed packaging with a time temperature indicator. You can see it on the right side below. And we ask our patients to return any unused drugs to the pharmacy so we can then verify the quality. We are looking whether the seal bag is still unopened to ensure authenticity, but also to make sure that the medicine has been protected from influences of humidity and light. We are looking at the shelf life and also through the temperature indicator, whether it had been stored according to product label claim. And if that was all the case, we could then redispense it to another patient who was enrolled in the program. In that case, we would also reimburse the money to the initial payer, which is a healthcare insurance company in our healthcare system. But this was an important motivation for our patients because they thought pharmacies shouldn't earn money from this approach, but it should really go back to society. We are really proud that this was actually world's first program in which medicines were redispensed in clinical practice, in which the quality was assured. So we studied that in the ROAD study, for which we approached 2,500 patients, a little bit less, and eventually slightly more than 1,000 patients participated in this study. They were treated in 4 different hospitals in the Netherlands, and each patient participated up to 1 year in the study. And Eric already gave it away, but we showed in this study that by redispensing unused oral anti-cancer drugs, we can prevent 2/3 of the waste. This concerns 1.7% of all the oral anti-cancer drug packages that were dispensed, which seems like such a minor part, but that makes sense because most packages are fortunately being used, and obviously we also have preventive measures in place. So looking at the reasons for quality disapproval, you can see that the seal of the packaging being opened was the main reason for quality disapproval. And often this was accompanied by damaged packaging and a missing time temperature indicator, because then the patient would simply have started using that specific drug package. In the light blue bar, you can see that in a minority of cases, we found a temperature breach, but that was always between the 25 and 30 degrees. But we might need to update that with the temperatures of today. So looking into the cost savings, we set the costs for the procedures. So it's the materials, it's also the staff and overhead costs for performing this redispensing program. And we compared that to the benefits of preventing waste. And that resulted in net annual cost savings of 576 euros. We then looked into a more optimized scenario because we didn't find any temperature breaches above 30 degrees. So then we decided what happens if we would only monitor temperature in case of a maximum storage temperature of 25 degrees. And we also shortened the shelf life criterion to 2 months because that is giving us enough time to redispense it. And by optimizing our procedure, you see that the cost savings are actually increasing because the procedure is getting cheaper and the benefits are greater. I also performed multiple regression analysis to see what patients are specifically at risk of having positive cost savings, which are patients using targeted therapies for shorter treatment duration, so typically up to 6 months. And focusing on those patients could even further increase cost savings up to 1,350 euros per patient per year. So that's great, but we're on a sustainable healthcare conference, so I bet you all are interested in the environmental impacts, which we also measured to a cradle-to-grave life cycle assessment. So at one hand, we performed an LCA of the burdens of our procedure, especially the materials that we were using. And at the other hand, we performed a cradle-to-grave assessment of the production, distribution, and incineration value of 6 oral anti-cancer drugs that we then extrapolated to the entire sample. We found that in the initial scenario, which you can see on the upper side of the graph, that the burdens are actually outweighing the savings. And that was due to the time temperature indicators that we were using, and specifically their batteries. However, if we are then looking into the optimized quality assurance procedure, in which we use those time temperature indicators only for temperature sensitive medicines, we see that we could save up to 2 kilograms of carbon dioxide emissions per patient per year, equaling an effect of 100 trees per 1,000 patients. So these results also helped us to inform a guideline which we have developed in collaboration with the Dutch Association of Hospital Pharmacists. And then finally, I looked into barriers and facilitators to implementation by interviewing 35 involved stakeholders, including pharmacists, pharmacy technicians, oncologists, specialized nurses, patients who participated, and also patients who did not want to participate in the program. And that provided recommendations for implementation. So with that, in 2024, I was also presenting at CleanMed, and we were very happy with the results. I made my PhD thesis out of it, and we could say, let's implement it in clinical practice. But there were still some hurdles to go, and a lot has happened in the past 2 years. And to take you a little bit along in that journey, I would like to give the floor to my colleague Ella Jansen.
Thank you very much, Lisa Marie. Indeed, I will take you through the most recent developments, because I think you can all understand that with the initial results of the first road trial, we were very excited and super keen to scale up this initiative across more diverse settings and more hospital sites in the Netherlands. However, at the time being, there was still a legal barrier, namely the Falsified Medicines Directive, as part of the EU pharmaceutical legislation. So we still required a ministerial waiver to perform a next study, which luckily we were granted, and we could include 13 hospitals in this next trial. But I do want to take you through a recent development that has happened, because we are very excited to share that the EU Parliament has agreed upon a revision of this EU pharmaceutical legislation to now allow member states to redispense unused medication. I am saying allowing, not obliging them, because it's a choice for each member state to implement this. So they are, it's not mandatory, but at least it's no longer a legal barrier. And then you are probably all wondering, well, that's great. What type of medication can we now redispense? It sounds easy. It's an easy process. But of course, this also needs to be regulated. So there are some strict terms and conditions that apply, and the most important ones are listed here. So, for instance, a medicinal product can only be redispensed by the same pharmacy of which it was initially dispensed. A receiving patient needs to provide their explicit written consent to receive a redispensed package. Medicine package can be redispensed only once, and of course there need to be safeguards to ensure that the medicinal product was not tampered with, and that the storage and transport conditions are respected. But then going back to the Road 2 trial, that was implemented in 13 different hospitals, now academic, teaching hospitals, and general hospitals. And as Lisa Marie nicely indicated, implementation is key. And it sounds really easy to have a good pilot study and to then just implement it and scale it up. But actually, we learned from our barriers and facilitator study that context is key and preparation is key. So before commencing the next trial with the 10 newly added hospital sites, we conducted a context analysis in which we looked whether they were actually capable and had the opportunity to perform this study, but also whether the pharmacy staff and prescribing clinicians were motivated to do so. And from this context analysis, we learned that communication about targets and expectations, support from a project leader, cooperation between physicians and pharmacy staff, and of course, sufficient personnel is key for the adoption of this new intervention. But also we learned that the pharmacy staff needs to be motivated. They need to understand what it means to work on a sustainability initiative and feel that it's needed from a societal perspective, but also really feel the need that is a priority, so they will make the time for it. Otherwise, it's hard to change behaviors. You can continue. So I won't dwell on this too much because I think Lisa Marie already showed a lot of very nice results from her Road 1 trial, and we are still working on data analysis at this moment. But to just give you some very quick first results, we approached over 5,900 patients, and in total, 2,300 patients ended up participating in Road 2. And then in terms of the returned packages, we saw that 9% of all patients returned an OAD package. In total, 504 OAD packages were returned, and 88% of them were approved for redispensing, providing a value of around 1 million euros, so quite a lot of money. However, we are still analyzing what this means in terms of cost saving. As Lisa Marie explained, we need to consider the cost of the process and materials as well. And we'll look into the environmental impact reduction and do some regression modeling as well to see whether we can identify certain in our case mix, certain groups or certain treatment patterns that are statistically significantly leading to more opportunities for redispensing. And I think that ties in nicely with the final thing that I want to share about implementation, because the second Road trial in 13 hospitals was also really about seeing why an intervention works, why it might be effective or more effective in certain places compared to other places. And so we looked at 7 implementation outcomes throughout the process of our trial. We measured interest prior to the study. We had questionnaires at 6 months and 12 months of the study, and performed frequent site visits to ensure that the process was implemented the way we wanted to have it implemented, but also learn from what's going well and what barriers might still exist so we can further optimize our process. And so with that, I'd like to thank, because we are not alone, thank the main research team, all the participating hospitals of the trials, but also our biggest supporters, the Ministry of Health and the Dutch Association of Hospital Pharmacists, and of course, some of the funding bodies that we received for this study. And like to conclude by saying that redispensing of unused oral anti-cancer drugs not only reduces waste, it also generates cost savings and can provide environmental benefits, and by that contributes to the sustainability of cancer treatment. And I invite you all to join this movement, be part of the solution, and make pharmaceutical use practice more circular. And I think we'll hear from a Danish example how they are doing that.
Thank you, Ella, and thank you also, Lisa Marie, for the excellent presentation. As I said, the Netherlands was one of the main. Well, it was actually the first country in Europe focusing on this approach to redispensing, and the results are really good. There are, I think, a couple of papers that have been published, and some people are asking in the attendee chat if these are available. So please, if you can share them with them, I think they would be grateful. And I'm particularly happy to see all this work, all these projects evolving, because as Lisa Marie said, they have been joining us in CleanMed, which is the week where we kind of socialize all the work around sustainable healthcare in 3 days with experts from across the different sectors, and seeing how these projects are scaling up their impact. It's something really, really positive for us. It's like it feels part of the the positive results of all the CleanMed conferences that we have been running in the past few years. Well, thank you, both of you. And we have another speaker today joining us from Denmark. In this case, they were, I think, the fast followers of all the work that the Netherlands did in terms of redispensing. And with us, we have Caroline Strootwijk, who is an specialist consultant at Health Innovation Center of Southern Denmark. And I think her presentation will speak for her, so I will not spend more time introducing her. So Caroline, the floor is yours.
Thank you so much, Eric. And I'd like to thank you for letting us present the DanRoad project on redispensing oral anti-cancer drugs in Denmark. This project is managed by the Department of Clinical Pharmacology at Odense University Hospital, and I'm speaking on behalf of the whole DanRoad team today. And I'm very excited to be here. But first, before I get to the project, I'd like to give just a little bit of context in a Danish setting, because the Danish regions that run the hospitals in Denmark have an ambitious strategy on green hospitals, on focusing on reducing climate impact of the healthcare sector. And in this strategy, there are some specific areas of interest, and one of those is sustainable medicine. And then these different areas of interest are split out across the country with different responsibilities for figuring out what good initiatives might be good to scale up across Denmark. So the region of Southern Denmark and Odense University Hospital have a national lead on sustainable medicine, and therefore has a responsibility to look at different initiatives that may increase our sustainability within medicine in Denmark. And so part of that is to pilot different solutions, is to coordinate and share information. And so DanRoad is one such example of an initiative that we're trying to pilot to then focus on scaling it up to the rest of Denmark. So it starts locally, but in the planning of the whole DanRoad project, the national scale up is a part of the whole planning. And we'd also like to really thank Ella, Lisa Marie and Charlotte Becker and their colleagues for generously sharing all of the knowledge that they have from the road study. It is so great to be able to stand upon the shoulders of others who've already learned a lot and have a lot of important knowledge and results. And they've been very good in supporting us in how to approach this in a Danish setting. So I'd just really like to thank them. And say that if others would like to also learn from the road study and DanRoad study, don't hesitate. It's so great to have someone to work together with and build upon. So the DanRoad study in Denmark, or the DanRoad project, as I think also both Lisa Marie and Ella kind of hinted at, there's a lot of implementation to work on, and there's a lot of context to be aware of when you're implementing something like this, which is very different from standard practice in Denmark on dispensing medicine. So we have really looked into how to do it in a Danish context, and we have talked to lots of different stakeholders to try and figure out how to do it. One really important first step is to figure out to get approval to do it from the Danish Medicines Agency. So we've had great dialogue with them about how we could do it in a Danish setting. And it's important to say that there is a difference here from the Netherlands, where they were given a waiver to do it, whereas in Denmark we found a way to do it within the existing legal framework. So that's just a little important detail. And the way it's done in Denmark is that the medicine is dispensed from the clinical department to the patients, not from the pharmacy. And it is also returned to the clinical department and redispensed from the clinical department. So returned medicine does not come back to the pharmacy. It stays within the clinical department. I'll get a little bit back to that. And also just stating very similar to road, that the quality criteria that are really important is that we put the medicine in a sealed bag, and we check when it's returned that the seal is not broken, so it hasn't been tampered with, that we have intact original packaging. An expiration date of over 3 months. I heard from Road they went down from 6 to 2 months, and that it's been stored correctly in accordance with the manufacturer guidelines, for example, in case of temperature. So that's also what we test when the medicine returns to us. The DanRoad project relies heavily on user involvement in order to find the best way of doing this that can seamlessly fit into the daily practices at the hospital that we have involved in DanRoad. So in DanRoad, it's the Department of Oncology and Department of Hematology at Odense University Hospital. And so we've done workshops with different staff groups from them, and also from the pharmacy and the clinical pharmacology to try and figure out how to do it into detail, how to implement this in a Danish setting and in Odense University Hospital. And the methodology that we've used for this is a service blueprint methodology that you can see in this kind of turquoise box, is that we're really looking into what happens to this medicine throughout the journey, when it is returned, when it is redispensed, and so on. So there are lots of different steps that we need to be aware of. And across those steps, we need to think about who is involved, which actors are involved, what do they do, what are the workflows that we're integrating with here, where does it happen, down to the rooms and what's the space like and everything, which physical elements do we use, the bags, the temperature loggers and so on, and which systems do we integrate with. So we had lots of discussions into details of what do we do when we run redispensing processes like this. And it's been really, really important to do this user involvement so that everybody is on board and ready to do this in a good way that fits for their everyday life. We know that the healthcare staff are busy people. This needs to work seamlessly, really. Our pharmacy staff also tested different temperature loggers and seal bags just to find the best solution that they could find. I think it's the same ones as in Road, but they need to check that themselves. So how does it work? It's not very different from the Road study, but there are a few things that I'll just get into. But when medicine is dispensed, it is put in this individually sealed bag with a temperature logger. And the patients are included through dialogue with their doctor or nurse. And then they will also be given written information, and they will sign a written consent form. And when the medicine is then dispensed, they will be told how to handle it and what to do with it and when to open it and so on. They get it from the clinical department when they visit and have a consultation with their doctor. And they also, if for some reason, side or whatever, they don't need to they don't need to use the medication and they need to bring it back, they will just bring it the next time they visit the department, the clinical department. So they don't have to come in just for that, because we don't want to burden the patients and their caregivers, but they will return it next visit. Then the the medication that's returned, we do the quality control. It's very important that we keep the returned medicine separate from the existing medicine that we have and in a locked cabinet and so on until it's been quality controlled. And then it will be put in a special place for redispensed medicine so that it can be given to another patient who has signed up for this. And then it continues as such. As with user involvement, we've also worked a lot with information materials for these different stakeholder groups. So the healthcare staff, for their dialogue and what they need to do, there's some guidelines on how to do that, a pocket guide. And we've also done flyers for the waiting room for patients and caregivers so that they can get a little bit of an introduction to what this project does. And actually we find that the patients do see this in the waiting room, and so they will actually know a little bit about it when the healthcare staff then talk to them about becoming a part of it. Maybe I just want to reiterate the differences from the Netherlands, also to show that there are different ways to do it depending on context. And so one part that's different, I think, is that we inform the patients and caregivers during a conversation with their healthcare staff. We don't write out to them. So it's in a dialogue that they get included. The medicine is dispensed and returned to and redispensed from the clinical department, not the pharmacies. And also, as in the Netherlands, this medicine is free of charge for the patients, but the department that pays for it is the clinical department or the hospital and the region. And so when it is returned to the same hospital department and redispensed from that same hospital department, there's no need for reimbursing any money. So that makes it easier in that respect. Yeah. The pilot, the Dan-Road pilot, started on the 1st of December, so that's about 6 months ago. And we've worked a lot on, as I said, the details of how to do it, and also a very, very detailed implementation plan, how to inform people when and where and lots of different times, and a hypercare approach to being available if there's any kind of need for it in the first months of the implementation. And so far, we don't have the results yet, so we can tell you about the experiences and what we find so far. The clinical staff are very happy and positive about this initiative, and they think it makes a lot of sense. They don't like the waste of medicine. Also, the patients are really positive, and we haven't actually noted down who says no to participating, but it is the experience from the healthcare staff that include them that basically nobody says no. Everybody kind of wants to be a part of it. They've had a few patients say no, and that's also very fair. So it's all very positive experiences, and also it kind of confirms that it is feasible to do this. Having said that, there are definitely things that we can optimize in the way that we do this, where it can become even better. That's also what we heard from the road study. When you do something like this, that's very different from a normal procedure, and it's an innovation, there will be learnings where we can do iterations and get even better at it. So we get the most out of it. And if you just want some numbers on what we've had returned, we've only been going for 6 months, and it takes a little time before people luckily get side effects and need to bring back the medicine. But we've had 15 returned packages so far. 40% have been approved for redispensing, which equates to around 50,000 euros. And for the included patients that we have in this one hospital, that is around 200 euros per patient that we can save. So, and we can definitely optimize and we can definitely get more out of it, but there's a lot of potential already. And then I will give you a first sneak peek at our investigation of user perspectives. Nobody else has really heard about this yet, so you are really the first to get to know this. We've done a three-part investigation of user perspectives. The first was qualitative interviews with patients and caregivers, where we really wanted to get in depth to understand what kind of affects the perspectives that they have on redispensing medicine. And the main insights are that they are both patients and relatives are very positive and willing to be a part of redispensing medicine. They absolutely see and are frustrated about medicine that is wasted when they bring it back and they know that it will be discarded. So for them, that's frustrating, and it actually has a lot of feelings for them. So they would like that medicine to be of use to somebody else. We also saw a very high trust in the healthcare sector and healthcare staff. Denmark is generally a high trust society, so it's not surprising, but it is important. Also, the quality checks are really important because that's kind of what guarantees to them that the medicine is okay and has the effect that it needs to have. And that is extremely important for this vulnerable target group who obviously are very dependent on the medicine working as it should. Based on what we found out from the qualitative interviews, we found the relevant themes to then do a larger national quantitative survey through the Danish Cancer Society to find out what the general perspective among patients and caregivers are in Denmark. And the insights from here are that 85% think that redispensing medicine is a good idea. 88% are willing to receive redispensed medicine. And 92% really trust the healthcare staff. And what we can see in the correlations is that this trust in healthcare staff influences the willingness to be a part of it. So these are really high numbers, and there's a lot of positivity in Denmark about this. We also did a qualitative focus group interview of 4 of them with different staff groups, with nurses, pharmacy staff, doctors and managers from 3 other hospitals in the region, so who are not a part of the pilot study, just to find out what their perspectives are. And the main insights from here is that all staff groups consider redispensing really meaningful and absolutely feasible. But it's very important that there are very clear roles and procedures, and that there are good practical solutions for how to do it easily. They also really care about the quality checks and the effect of the medicine, of course, and that information is so important and for all different stakeholders, and maybe it's different what each stakeholder needs to know. So the main conclusion for these user perspective investigations is that all user groups are ready and positive about redispensing medicine, and everyone is motivated by reducing waste and being more having a more sustainable use of our resources to the benefit of patients. And that practical implementation into detail is very important, and that the healthcare staff are absolutely invaluable ambassadors for redispensing medication. So I know that there is a Q&A session, but if you otherwise have questions afterwards, you're welcome to reach out to me, Caroline, or to Maria, who's the project manager of Danroad, or Sissel, who has the national lead on sustainable medicine. So thank you very much.
Thank you for the presentation, Caroline. Just quoting something that you said, and I think it's the key point that I want everyone to get from this session is that it is feasible to do this. It is feasible. Now it can be backed by national regulation because it has been approved at the EU level, and then countries will need to decide, as Ella explained. And then quoting also one of the comments in the chat, so many solutions are so logical. Like, I cannot believe how we were not thinking of this earlier. All right. Well, thank you very much, Carolina. Perhaps we can bring up everyone on the screen again, and we can answer a couple of questions very shortly because we are close to the end of our time. But I saw that there are a few questions, and thank you, Lisa Marie, for answering some of them also in the chat. But there are some questions about patient engagement. One of them was asking if patients were able to say no to participate in this, which I think was already answered. But there is also one question asking what was the main reason for patients not to join this initiative. Was it quality concern? Was it any other aspect? I don't know who of you wants to jump in first for this question.
Yeah, I think I can reflect on that because I specifically aimed to interview these patients, which was actually quite hard because they weren't open for the idea. So it was really hard to recruit them for an interview. However, I think I've interviewed 5 of them, something like that. And the main argument was that they were already being so ill and they got so many documentation from the hospital at that moment that it was just another letter to them. And there was nothing to win. It was just more thinking, and their brain was foggy and they didn't feel like they had the space to read it carefully and sign the document. And I think that's also the answer to the other question. Up to now, we always have asked for informed consent for all patients who participated in the programs, but that was really felt as a burden. And then the gains are on a societal level, but the burden is on a personal level to very ill patients. So I think we should take that into mind.
All right. And I think perhaps, Caroline, you can also elaborate on that because the experience is slightly different in Denmark, where I think clinical experts are more involved, right? Can you explain that?
Sorry, what did you say with the experts?
The clinical staff is more involved also in outpatient.
Yes, I think that the fact that the clinical staff are talking to the patients about it, they don't hear about it basically in a letter. It definitely makes a difference because they trust the person that is helping them with their disease and their healthcare. So this trust in the healthcare staff means that they're very open to it. But we did also ask in the quantitative study that we did for the people who didn't think it was a good idea. It wasn't that many, it was 15%, but we asked them why were they worried about this. And it was the kind of the quality of the medication, but mostly the fact that it had been in somebody else's home kind of made them unsure about it.
All right. Thank you very much. There are also a couple of questions about the possible replicability in other drugs. Is this something that you have also considered in your work? And perhaps we can start with Caroline this time, now that I see she's nodding.
Yeah, I mean, we are only within the first 6 months of the pilot study in Danroad, so we need to learn a lot from this one first, but it is definitely on the table that we're going to look at which other drugs would be relevant to redispense in the future. So I think that it is definitely something to look at, and maybe we need to be very clear on which criteria make which drugs more relevant to work with redispensing for. And that's something to definitely get a bit more knowledge about, so that we can then decide on what to do this with. Yeah.
All right. Lisa Marie
Yeah, I
or
think
Ella,
to
do you
add to
want to?
that, yeah, I
Yes.
think a main criterion is that we frequently waste the medicine. So that's the most important criterion for being for providing environmental benefits. So I think that's important to keep in mind. And also, I put the chat about the biologicals, and the problem there is that they are not stored correctly, so the quality can't be guaranteed in a redispensing process. So that's why we are not focusing on biologicals right now.
All right, perfect. And very, very last question, and this is the tricky question. If there were any healthcare professional or any healthcare manager in this conversation today that would like to start a redispensing program next week, already on Monday, when the heat wave is gone, what would you tell them? Like, which piece of advice would you share with them? How would you motivate them? One phrase, you have, I think, around 20 seconds each. So do you want to start, Ella?
Sure. Yeah, I would say build a business case, show the positive results that this can bring for your company, hospital, whatever it is, and build from the evidence that's out there and the help of the coalition of the willing that we are to assist you with this.
All right, brilliant. Caroline?
Yeah, absolutely. Thank you for saying that, because then I can add on that and say, just talk to all the different stakeholders, have a dialogue with them, let them be a part of it, and so that they also feel kind of an ownership of this idea and the potential of it.
All right, Lisa Marie?
And I think it's also about courage. So let's just stop wasting opportunities.
All right, great. You have said 3 different things, but all of them are in the same direction, basically, which is we are here to help. So let's build up on this community of practice. Let's see if in a few years we have another session in CleanMed where other countries are explaining what they did. That would be a brilliant outcome for this session. And thank you very much for being with us today. It was a real pleasure to have your expertise here, and I will ask all the participants to contact you directly, because I think you have a lot of things to share that obviously in 45 minutes is a bit more difficult. I would also like to thank Marina, who is our colleague doing the virtual assistance of this session, who made this possible, and of course all the colleagues working on CleanMed from Brussels, from London, and from other locations. And of course to you for joining us today, which I hope it won't be the only session that we'll watch today, because we have actually a few sessions. For example, at 12:45, we'll have the session Cutting Carbon and Waste, how intravenous to oral switch programs drive hospital sustainability. And guess who is going to be your moderator there in a few minutes? Myself. Then tomorrow we have at 12:30, Can cancer treatment be sustainable? Green practices in non-communicable diseases, which links very nicely to what we have been discussing today. So I hope to see many of you there as well tomorrow. And tomorrow at 2:45, we have also endocrine disruptors, from environmental impact to community-led solutions, as well as a great workshop tomorrow on developing mitigation and science-based targets, aligning emissions reductions with the climate science. Well, thank you very much again for joining this session, and I hope you enjoy the rest of CleanMed Europe.